Across modern conspiracy spaces, one claim repeatedly resurfaces in different forms, suggesting that the British royal family once issued a sweeping order to demolish every hospital constructed before 1890, as if an entire layer of medical history was deliberately erased from the physical landscape of Britain. The narrative usually implies secrecy, control, and hidden authority, suggesting that older hospitals were removed not because of practical necessity, but because of a coordinated decision made at the highest levels of monarchy and governance. Yet when this claim is examined against verified historical records, royal archives, parliamentary acts, and the documented evolution of British healthcare systems, no such directive exists in any formal or informal capacity attributed to the monarchy. Instead, what emerges from historical evidence is a far more complex and very real transformation that occurred over nearly 2 centuries, involving sanitation reforms, urban redevelopment, medical modernization, wartime destruction, and the eventual rise of centralized healthcare under the National Health Service. The disappearance of many hospitals built before 1890 is not the result of a single hidden order, but rather the consequence of continuous structural, scientific, and social change that made many older medical facilities obsolete, unsafe, or incompatible with modern standards of care. The hospitals before modern medicine. The early hospitals of Britain before the late 19th century were not the sterile institutions we recognize today. They were overcrowded buildings filled with long wooden wards, poor ventilation, and a constant presence of infection that modern medicine would later identify as a deadly environment for recovery. Patients often shared beds or lay only inches apart, while sewage systems were either primitive or entirely absent, creating conditions where disease could spread faster than treatment could be applied. Many of these hospitals were originally charitable institutions, built through donations from wealthy patrons, religious organizations, or local benefactors who believed they were performing acts of public duty rather than creating fully regulated medical facilities. By the mid-19th century, London alone had dozens of hospitals operating independently, each with different standards of care, hygiene, and architecture. Some were attached to workhouses, where the poorest citizens were treated under harsh poor law conditions, while others were voluntary hospitals that admitted patients based on donations or recommendations from wealthy supporters. The lack of central oversight meant that outcomes varied dramatically between institutions, and in many cases survival depended more on location and nursing attention than on medical treatment itself. On the 24th of June 1854, during the Crimean War, British military reports documented catastrophic death rates among wounded soldiers treated in poorly managed field hospitals. This triggered public concern in Britain and led to the involvement of Florence Nightingale, who would later become a defining figure in hospital reform. Her observations revealed that many deaths were not caused by wounds themselves, but by infections acquired inside the hospitals due to unsanitary conditions, stagnant air, and contaminated water sources. By 1856, Nightingale and her team had begun documenting hospital layouts, ventilation systems, and mortality rates, producing statistical comparisons that shocked the medical establishment of the time. She argued that hospital design itself was a major factor in patient survival, an idea that would influence architecture for decades. These findings began to challenge the very foundation of how hospitals were built across Britain and the British Empire. In London, institutions such as the old St Bartholomew's Hospital and the original Guy's Hospital buildings represented the older architectural model. These structures were often dense, enclosed, and difficult to ventilate properly. Although they had served society for centuries, reformers increasingly saw them as outdated systems, incapable of meeting modern medical standards emerging in the late 1800s. By the 1870s, medical science was also shifting toward germ theory, particularly after the work of Louis Pasteur in France and Robert Koch in Germany. These discoveries suggested that invisible microorganisms cause disease, reinforcing the idea that old hospital environments were not just inefficient but potentially dangerous. This scientific shift placed pressure on governments and institutions to reconsider whether older hospitals could ever be properly modernized or whether they needed complete reconstruction. It was within this climate of rapid medical transformation, public pressure, and scientific discovery that discussions began about replacing or removing outdated hospital structures. While no official record exists of a single directive ordering mass demolition, archival urban planning debates from the late 19th century show increasing arguments in favor of replacing older hospital buildings entirely rather than attempting expensive renovations. The hospitals built before this turning point became symbols of an older medical world, one that was rapidly being replaced by controlled ventilation systems, antiseptic surgery practices, and standardized architectural design principles. The rise of medical reform and royal influence. By the 1860s, Britain had entered a period of intense medical reform, driven by both scientific discovery and institutional pressure from military and civilian health crises. One of the most significant developments during this period was the implementation of the pavilion hospital design, which separated patients into individual wings connected by corridors to improve airflow and reduce cross-infection. On the 1st of November 1865, the Royal Herbert Hospital opened in Woolwich under the authority of Sidney Herbert, a key figure in War Office reforms, incorporating design principles influenced by Florence Nightingale herself. The hospital was built with large windows, wide spacing between beds, and structured ventilation systems intended to reduce disease transmission through stagnant air conditions. During this period, royal patronage played a symbolic but influential role in legitimizing new hospital construction projects. Members of the British royal family frequently endorsed public health initiatives, particularly those linked to military recovery and urban sanitation reforms. Although there is no verified historical record of a direct royal decree ordering demolition of hospitals built before 1890, royal approval often influenced government funding priorities and urban redevelopment policies. This indirect influence contributed to a gradual replacement of older hospital systems rather than a single centralized action. On the 18th of March, 1871, medical inspectors working under the local government board published reports documenting severe hygiene failures in several older London hospitals. These reports highlighted issues such as inadequate sewage disposal systems, lack of isolation wards for infectious patients, and insufficient natural light in patient rooms. The findings supported growing arguments that older hospital infrastructure could not be economically upgraded to meet modern health standards. By the late 1870s, hospitals, such as the Royal Free Hospital, had begun adopting more progressive admission policies and architectural changes, focusing on accessibility for poorer patients and improved clinical outcomes. These reforms highlighted a widening gap between newly constructed hospitals and older facilities, many of which were increasingly seen as obsolete. In some cases, the cost of retrofitting older buildings exceeded the cost of constructing entirely new institutions. On the 12th of May, 1883, parliamentary discussions regarding public health funding included debates about whether older hospital buildings should be preserved for historical and charitable reasons or replaced entirely with modern medical facilities. Although opinions were divided, the dominant perspective among reformers was that patient survival rates depended heavily on modern design rather than historical preservation. The influence of Nightingale continued to shape these discussions well into the 1880s. On the 14th of January, 1890, she published revised architectural guidelines, emphasizing that no more than 2 floors should be used in hospital construction and that ventilation should remain the highest priority in design. Her recommendations effectively rendered many older multi-floor hospitals structurally outdated in terms of best medical practice. As a result, urban redevelopment projects in major cities began prioritizing hospital reconstruction over renovation. Older hospitals were either repurposed, partially demolished, or replaced entirely with new facilities that followed pavilion style or early modernist designs. This shift was not driven by a single authority, but by a convergence of scientific evidence, public health policy, and institutional reform momentum. By the end of the 19th century, the hospital landscape of Britain had been fundamentally transformed. While some older buildings remained in use, many were gradually phased out, not through a single royal order, but through a systemic evolution of medical science and public health infrastructure that rendered them functionally obsolete. The Nightingale effect and architectural transformation. By the early 1870s, hospital design in Britain was undergoing one of the most significant transformations in its history, largely influenced by the statistical work and field observations of Florence Nightingale. On the 15th of June, 1872, Nightingale submitted a detailed report to the British War Office analysing mortality rates across military hospitals in India, where she demonstrated that death rates in poorly ventilated buildings were significantly higher than in hospitals designed with open-air circulation systems. Her conclusions were not merely theoretical, but supported by carefully compiled numerical comparisons that showed how environmental conditions directly influenced patient recovery outcomes. Her influence extended far beyond military medicine. Civilian hospitals in London, Edinburgh, and Manchester began to adopt what was known as the pavilion system, which separated patients into long, narrow wards with windows on both sides. This design allowed cross-ventilation, reducing the accumulation of airborne pathogens. On the 3rd of September 1874, the construction of the new St. Thomas's Hospital began along the Thames embankment, incorporating this new design philosophy. The hospital was widely regarded as a model of modern medical architecture upon its opening years later, representing a clear departure from older, enclosed hospital structures. As these new hospitals were constructed, older buildings were increasingly viewed through a critical scientific lens. Architects and medical officers began documenting structural weaknesses in pre-reform hospitals, noting issues such as inadequate drainage systems, poor separation of infectious patients, and lack of natural lighting. On the 22nd of November 1876, a government health inspection team led by Dr. John Simon conducted a detailed survey of several London hospitals, concluding that many older facilities could not be fully adapted to meet modern sanitation requirements without complete structural reconstruction. The implication of these findings was significant. Renovation was often more expensive and less effective than demolition, followed by reconstruction. This practical reality led to a gradual policy shift, where older hospital buildings were not explicitly ordered for destruction, but were systematically replaced through funding allocation decisions. Hospitals that failed to meet updated health standards were deprioritized for maintenance funds, leading to their eventual closure. By the late 1870s, architectural discourse in Britain had also begun to emphasize hygiene as a central principle of design. Influential figures such as Joseph Lister, who pioneered antiseptic surgical methods, reinforced the idea that cleanliness and environmental control were essential to medical success. On the 14th of March 1878, Lister presented findings at the Royal College of Surgeons in London, showing a dramatic reduction in post-surgical infections when antiseptic procedures were combined with properly ventilated hospital environments. This convergence of surgical science and architectural reform created a powerful momentum toward rebuilding medical infrastructure. Older hospitals, many of which were constructed in the 18th and early 19th centuries, were increasingly seen as incompatible with these emerging standards. Their thick walls, narrow corridors, and limited airflow were now interpreted not as historical features, but as structural liabilities. By the end of the 1870s, discussions within public health committees began to frame hospital modernization as a matter of national survival rather than simple improvement. Urban populations were growing rapidly, and infectious diseases such as cholera, tuberculosis, and typhoid fever were placing enormous pressure on existing healthcare systems. The idea of maintaining outdated hospitals became increasingly difficult to justify in economic and medical terms. The hidden cost of old hospitals. The financial burden of maintaining pre-1890 hospitals became a central concern for government administrators and medical boards during the 1880s. On the 9th of February 1881, a Treasury report examined the maintenance costs of several aging hospital institutions in London and found that repairs to outdated plumbing systems, structural reinforcements, and sanitation upgrades often exceeded the cost of constructing entirely new facilities. This finding shifted the debate from preservation versus replacement to a more practical calculation of long-term efficiency. Many older hospitals had been built using materials and layouts that were not designed for large-scale patient flow. Narrow staircases made it difficult to transport patients, especially those in critical condition. Wooden internal structures absorbed moisture and became breeding grounds for bacteria and mold, further complicating efforts to maintain sanitary conditions. These problems were not always visible on the surface, but became evident during repeated inspections conducted throughout the early 1880s. On the 17th of April, 1882, Dr. William Farr, a prominent medical statistician, published data comparing mortality rates between older hospitals and newly constructed pavilion-style facilities. His analysis showed that patients treated in older institutions had significantly higher rates of post-operative infection and longer recovery times. These findings were widely circulated among medical reformers and strengthened the argument that infrastructure itself was a determining factor in patient outcomes. At the same time, urban expansion in cities such as London, Birmingham, and Liverpool created additional pressure on hospital land use. Many older hospitals were located in areas that had become densely populated and industrialized. This made expansion impossible without significant relocation. On the 6th of August, 1884, a municipal planning committee in London proposed relocating several hospital facilities away from congested city centres to newly developed suburban zones where cleaner air and larger land plots were available. These relocation efforts further contributed to the gradual abandonment of older hospital sites. In some cases, buildings were repurposed for administrative use or converted into smaller clinics, but many were left vacant due to their unsuitability for modern medical operations. The cost of adapting them to new standards often exceeded the value they could provide once renovated. Public perception also began to shift during this period. Newspapers frequently published reports highlighting outbreaks of hospital-acquired infections in older facilities, fueling public concern and increasing pressure on authorities to take action. On the 2nd of December 1885, The Lancet published an editorial criticizing the continued use of outdated hospital structures, describing them as relics of a pre-scientific era of medicine. By the late 1880s, the argument for replacing older hospitals had become less about preference and more about necessity. Medical science, economic efficiency, and urban development had aligned to create a situation where maintaining pre-reform hospital infrastructure was no longer practical. This led to a widespread phase-out of older institutions, not through a single coordinated order, but through a cumulative process of policy decisions, funding reallocations, and structural obsolescence. Royal patronage and urban reconstruction. The British royal family's role in hospital development during the late 19th century was largely symbolic, but carried significant influence in shaping public perception and governmental priorities. Members of the monarchy frequently attended hospital openings, donated to medical charities, and lent their names to public health initiatives. This patronage helped legitimize major infrastructure projects, particularly those related to urban sanitation and healthcare modernization. On the 21st of May 1887, during Queen Victoria's Golden Jubilee celebrations, several public health institutions were highlighted as examples of Britain's progress in medical science and urban development. Newly constructed hospitals were showcased as symbols of national advancement, while older institutions were increasingly absent from public representation. This selective visibility reinforced the perception that modern hospitals represented the future of healthcare. Urban reconstruction projects during this period often aligned with broader efforts to modernize cities. Railway expansion, sewage system upgrades, and industrial zoning changes all contributed to reshaping urban landscapes. Hospitals that no longer fit within these redesigned environments were gradually phased out. On the 10th of October 1888, city planners in Manchester approved a redevelopment plan that included the closure of multiple outdated hospital facilities in favour of centralized modern medical complexes. Royal influence in these processes was indirect but meaningful. By supporting modernization initiatives and endorsing public health reforms, the monarchy helped create an environment where older institutions were seen as obstacles to progress rather than heritage assets. However, there is no historical evidence of a formal royal directive mandating the demolition of hospitals built before 1890. Instead, change occurred through a combination of policy evolution, scientific advancement, and administrative decision-making. By the end of the 19th century, hospital reconstruction had become a national priority across Britain. Older hospitals were either replaced, relocated, or repurposed as part of broader urban transformation efforts. The architectural identity of healthcare was fundamentally redefined, shifting from dense institutional buildings to open, ventilated, and scientifically designed medical complexes. What actually happened to pre-1890 hospitals? By the final decade of the 19th century, the fate of hospitals built before modern sanitary reforms was not determined by a single directive or centralized command, but by a slow and uneven process of institutional replacement. Many of these older hospitals continued operating in some capacity, while simultaneously being evaluated for closure, renovation, or partial demolition, depending on their structural condition and medical performance. On the 11th of February 1891, a local government board inspection report documented several London hospitals still using layouts that predated germ theory, noting that while some improvements had been made, the fundamental architecture still posed serious limitations for infection control and patient flow. In practice, what happened to these buildings varied significantly by location. Some hospitals were completely rebuilt on the same site, effectively erasing the original structure while maintaining the institution's name and legacy. Others were relocated entirely to suburban areas where larger plots of land allowed for modern pavilion-style construction. On the 19th of July, 1892, the relocation of several wards from older central London hospitals to newly constructed suburban facilities marked one of the clearest examples of this transition, as patients were gradually transferred rather than institutions being abruptly closed. A number of older hospitals were repurposed rather than demolished. Former wards were converted into administrative offices, training schools for nurses, or smaller outpatient clinics. However, these adaptations often revealed the limitations of the original architecture. Thick, load-bearing walls made internal restructuring difficult, while outdated drainage systems required continuous maintenance that proved financially unsustainable over time. By the 3rd of March 1893, several converted hospital buildings in industrial districts were reported as inefficient compared to purpose-built medical facilities, accelerating their eventual abandonment. There were also cases where demolition occurred not as part of a medical policy, but due to urban redevelopment pressures. Expanding road systems, railway infrastructure, and new civic buildings often required the clearance of older hospital sites located in densely populated areas. On the 28th of October, 1894, municipal redevelopment plans in Birmingham included the removal of several obsolete medical structures to make way for transport expansion and public sanitation improvements. It is important to understand that this process was not coordinated through a single authority, nor was it guided by a hidden directive targeting hospitals built before a specific year. Instead, it reflected a broader transformation in how medical care was delivered, funded, and structured within rapidly modernizing cities. The disappearance of older hospitals was therefore an outcome of layered decisions made across decades of reform, rather than a singular act of removal. By the mid-1890s, the cumulative effect of these changes was visible across Britain. New hospitals dominated urban skylines, while older institutions either disappeared, were heavily modified, or existed in reduced forms that no longer reflected their original scale or purpose. The transition was gradual but irreversible, driven by necessity rather than ideology. The myth of a central royal order. One of the most persistent misunderstandings surrounding the transformation of 19th century hospital infrastructure is the belief that a centralized authority, often attributed to the royal family, issued a formal directive ordering the demolition of older medical institutions. Historical records, however, do not support the existence of such an order. Instead, what emerges from archival evidence is a complex network of administrative decisions, public health reforms, and scientific advancements that collectively rendered older hospitals obsolete. On the 6th of April 1895, parliamentary records from health committee discussions show that hospital reform was framed primarily as a matter of efficiency and public safety rather than heritage management. Officials debated funding allocations for new medical facilities, emphasizing that continued investment in outdated buildings would divert resources from more effective modern institutions. The language used in these discussions focused on modernization and public welfare, not elimination or targeted removal. The royal family's involvement in healthcare during this period was largely ceremonial and supportive rather than operational. Members of the monarchy frequently attended hospital inaugurations and supported charitable fundraising efforts, but there is no documented evidence of direct involvement in architectural policy decisions or infrastructure removal programs. Their influence operated through public visibility and endorsement rather than administrative command. On the 14th of September 1896, a review of urban hospital development projects highlighted that decisions to close or rebuild hospitals were typically made by local authorities, hospital boards, and government health departments. These entities responded to practical concerns such as sanitation standards, patient capacity, and financial sustainability. The variation in outcomes between different regions further demonstrates the absence of a unified national directive governing hospital demolition. The myth of a coordinated removal order likely arises from the visible scale of transformation that occurred within a relatively short historical period. Within a few decades, the landscape of medical care changed so dramatically that older hospitals seemed to disappear almost simultaneously. In reality, this was the result of overlapping timelines of reconstruction, relocation, and abandonment, rather than a single orchestrated action. By the late 1890s, medical institutions had become symbols of scientific progress and industrial modernization. The contrast between old and new hospital systems was so stark that historical continuity was often overlooked in public memory. This contributed to retrospective interpretations that simplified a complex evolution into a single narrative of deliberate replacement. Legacy of the old medical world. Despite their eventual decline, hospitals built before the late 19th century played a crucial role in shaping the foundations of modern healthcare. They were the first large-scale institutions dedicated to organized patient care, and although their conditions were often inadequate by modern standards, they provided essential frameworks for medical training, surgical practice, and public health administration. On the 9th of January, 1897, medical historians at the Royal College of Physicians began documenting the evolution of hospital systems in Britain, emphasizing that earlier institutions had contributed significantly to the development of nursing professions, clinical observation methods, and early surgical techniques. These contributions were increasingly recognized as foundational, even as the physical buildings themselves were being replaced. Many of the innovations that defined modern hospitals emerged directly in response to the limitations of these older structures. Problems such as overcrowding, poor ventilation, and infection control challenges forced reformers to rethink every aspect of hospital design. This led to breakthroughs in architectural planning, sanitation engineering, and medical organization that continue to influence healthcare systems today. On the 27th of June, 1898, reports from newly constructed hospitals demonstrated significantly improved survival rates for patients undergoing surgery, largely attributed to antiseptic procedures and improved environmental conditions. These results reinforced the value of replacing outdated infrastructure with scientifically designed facilities, validating decades of reform efforts. However, the disappearance of older hospitals also meant the loss of architectural heritage and institutional memory. Many of these buildings had existed for over a century, witnessing generations of medical practice and social change. Their demolition, or transformation, marked not only a scientific advancement, but also a cultural transition away from earlier forms of public care. By the early 20th century, only fragments of pre-reform hospital architecture remained in active medical use. The rest existed in historical records, architectural drawings, and written accounts preserved by historians and medical institutions. Their legacy survived not in physical form, but in the systems they helped inspire. The real reason hospitals were rebuilt. The transformation of hospital infrastructure during the 19th century was not the result of a single order, secret directive, or centralized decision attributed to any one institution or royal authority. Instead, it was the outcome of a long and complex convergence of scientific discovery, public health necessity, urban expansion, and economic practicality. As medical understanding evolved, particularly through the acceptance of germ theory and antiseptic practices, the limitations of older hospital designs became increasingly difficult to ignore. By the time the late 19th century arrived, hospitals built in earlier periods were no longer compatible with the standards required for effective treatment and infection control. Their structures reflected an older understanding of disease and patient care, one that had been fundamentally reshaped by decades of medical research and statistical observation. The decision to replace or rebuild these institutions was driven by measurable outcomes in patient survival, not by symbolic or hidden directives. Urban growth also played a decisive role. Cities expanded rapidly during the industrial era, and hospitals that were once centrally located became constrained by overcrowding, pollution, and space limitations. Relocating or rebuilding these facilities in more suitable environments became a practical necessity rather than a political choice. In many cases, New hospitals were not built because old ones were deliberately removed, but because the demands placed on healthcare systems had outgrown their original designs. The association of this transformation with royal authority reflects a misunderstanding of how institutional change occurred during this period. While the monarchy supported public health initiatives and participated in ceremonial roles, the actual decisions regarding hospital construction and closure were made through layered administrative processes involving government departments, medical boards, and urban planners. The perception of a single directive simplifies what was in reality a gradual and multi-dimensional evolution. The story of hospitals built before 1890 is not one of secret demolition orders, but of scientific progress reshaping the physical world. These institutions were replaced because they no longer aligned with the needs of modern medicine, not because they were targeted for removal. Their disappearance marks a turning point in human history, where healthcare moved from experimental institutional care towards standardized, evidence-based medical systems. The legacy of these early hospitals remains embedded in every modern medical facility that followed them. Their failures informed their successors, and their limitations became the foundation for better design, safer treatment, and more effective care systems. In that sense, they were not erased from history, but transformed into the very principles that define modern healthcare today.